This is an HRT tutorial from Precision Analytical, and today we're going to discuss a really fascinating and important topic if you are using transdermal hormones and especially monitoring them with laboratory tests as you're looking at HRT and BHRT within your practice. So the study that was published recently in North American Menopause Society has really highlighted and really confirmed the position that we've had due to reviewing this data amongst a lot of other data where people have really looked at these issues one piece at a time, and this is a study that kind of brought a lot of it together. Still some missing pieces, and we'll discuss those. But what we're looking at is percutaneous or transdermal. So transdermal progesterone delivery via creams or gels, and we're looking at serum, whole blood, saliva, and then blood spots, or in this, they're calling it capillary blood. And what they conclude is that basically the reliance on serum levels of progesterone for monitoring topical dosing is likely an underestimation of tissue levels, and there's an issue there in terms of overdosing. But when you really pick through the data, what it really does is lead you to a position of when you're using transdermal creams, and we will also discuss why the alcoholic gels are distinctly different. But when you're looking at transdermal creams, especially for progesterone, really none of the laboratory tests are going to give you meaningful numbers that you can use to reliably adjust dosages. And you can see just an excerpt from it here that has my name listed just in pointing out that I was actually involved in the study. You'll see some other names you may recognize. Dr. Zava's ERT did all the, or most of the analytical work. Dr. Stanzik, their group did the serum and the whole blood, and he's done quite a lot of work on this topic, and we thank him for sharing the data and allowing us to use this to kind of expand on our thinking when it comes to this topic. And really the heart of the issue is this, is when you take this transdermal progesterone cream, the serum values don't go anywhere, whereas the saliva and the blood spot values are going up. And so we need to look at this and figure out what that means. So generally speaking, when you're looking at hormones, and this is kind of your trend in terms of progesterone, is, early in life you don't make much progesterone, and then as a woman gets into the post-pubescent area, now every month you're ovulating, and when you ovulate, then obviously you're making progesterone in that young, healthy phase of life, and then of course you hit menopause, and then we enter HRT, where we're trying to replace the hormones there, and the idea being, that a woman once made a certain level of hormones, and we're going to give those back to a certain degree. And what we want to point out is that in most cases there is not simple equivalency between measuring with a laboratory test a blood, saliva, or a urine value on a young, healthy person, and then with HRT. There really can be some confusion and really a lack of correlation in terms of what's going on, depending on the hormone and the route of administration and how exactly you're going about measuring those. So we're going to come back to this graphic quite a bit, just in terms of the general concept of when you've got someone who's got a hormone deficiency and you give them a low dose of hormone, they're of course going to have a lower result. If you give them theoretically just the right dose, then they're going to end up in the normal levels, within the normal range, and if you give them too much, then obviously they're going to have excessive hormones. So if we look at this and just as a general model, we're going to say, okay, we're going to assume that we're giving sort of just the right amount, and then what we're going to do is test the people and say, okay, look, if you still have a low level of hormone, then we might want to consider giving you a little bit more. And if you have an elevated level, then we might want to back off the dose, right? There's sort of an assumption built into what we're doing that if, for example, in progesterone, if your target value, if you're well short of that, then, we're going to give a little bit more hormone, and we want to get it, of course, just right. But there are some assumptions built into this. Now, what we're going to discuss on a couple different levels are testing minions. And when we say testing minion, what we're going to be referring to is something that wreaks havoc on your testing system, your testing scenario, in terms of creating a result that doesn't actually reflect what's going on with the patient. So I'll give you an example. If we have a testing minion related to the actual quality of the lab work. I was once in a situation where we were running controls that were very high. And because of the way the lab test was set up, there was a lot of carryover. So the patient that ran right after the controls, which was about 10 to 20% of the patients, actually had an elevated value that wasn't real. So it was an artificial elevation. In another situation, we were running another test, and this was at a different laboratory, and there was an adjustment from one testing method to another, and it wasn't properly calibrated. And so for years, there were more people who were actually legitimately within the reference range that actually ended up with a low value, and so you can end up with a false low and a false high. Now, the subject of this tutorial is not lab quality, but obviously that's a pretty key issue in terms of making sure that when you're making a clinical decision off of a low result or a high result, that those are actually legitimate values. So we want to avoid testing minions, and I'm going to do what I'm going to do now is go through just a really quick example. So we want to get into this transdermal hormone issue, but I want to walk through sublingual hormones because it makes, I think, a really good point about how easily a particular scenario can be disrupted in terms of trying to get meaningful data. So when we're looking at serum, saliva, and urine testing with sublingual hormones, we've got three distinctly different issues going on with each one of these, which are actually pretty difficult to overcome with sublingual hormones. So with serum testing and sublingual hormones, you've got a speedy minion. If you look at this situation here, and we've got 3 different doses of testosterone, you can see that you get increasing levels, this is in females, of testosterone. But what you'll notice is that at just 3 hours, you're pretty much already back to baseline, and all of the 3 have converged, such that when you try to test out that far, then there's really nothing to see. The hormone's already gone. But if you test early on, then it's way too fast to try to catch a number that's actually going to work, that you can really say, okay, I'm going to make a clinical decision and change my dosing based off this number. So if the values go up and down very, very quickly, then it's really going to be difficult to get a number that you can really have a lot of confidence in, so that's a problem. Now, with sublingual hormones, you've got an even more significant issue with saliva testing, and that is the hormones are in milligrams, usually in supplements, and in saliva, they're in picograms. There are 1 billion picograms in a milligram, so this creates a huge problem, and that is the contamination minion. So these results are going to go up super high and going to be left just astronomically high for such a length of time that there really isn't any value in testing. So the contamination in the mouth lasts longer than the increased blood levels. So there's really not anywhere in there where you can test and get a meaningful value. So for me personally, when I take testosterone sublingually, which I don't do routinely, but for the purpose of research, my baseline values are usually around, let's say, 80. Okay, so my personal levels peak when I take a troche at about 100 million. So the results there are of no value, and a lot of times people will say, well, if you wait 30 hours, then you can test. Yes, at 30 hours, you're going to get either residual contamination or a baseline value, right? Remember that the systemic level of hormone that increases is back down in 3 hours. That level of contamination hits 100 million up in here, and yes, that's going to come back down eventually, but by the time it gets back down, there's really no meaningful data to be had relative to that surge of hormone that you just put under your tongue that rather instantaneously increased your systemic exposure to that hormone. So it really doesn't work very well. So with urine testing, it's a completely different reason that it's tricky to use sublingual hormones and get a meaningful value from urine testing. When the hormones are taken, they get into circulation. Now, urine's going to get its fair share of those hormones. The hormone that goes under the tongue, absorbs there, gets into circulation. Part of that ends up in urine. That value is actually a meaningful value. Unfortunately, It doesn't work if you swallow any of it, because what happens when you swallow it is it goes into your gut. You get first pass metabolism, hormones that go into the gut, get conjugated, end up in your urine. Those hormones have never been in systemic circulation. And from my own personal research, I find that I swallow about 20 to 50%, even if I'm being careful, and that will create a very, very significant increase in the urine levels, and you really can't account for that. So, can testing help monitor dosing with sublingual hormones? I think it's rather challenging for any of the tests to work well to get meaningful data. So I say that to say we need to be open-minded, not just about, I'm a saliva tester and I'm going to consider urine, or I'm going to consider blood, or I'm a blood tester and I'm going to consider an alternate method. We should be open-minded in that sense, but we should also be open-minded to the fact that given a particular scenario, it is possible that none of the tests, for various reasons, may actually work well to monitor therapy. So then, can testing help monitor dosing with transdermal hormones? That's what we want to look at. Now, the reason that this has been so complex historically, and it is a very complex topic, is the increase in hormone, which is kind of what we're looking for, really depends on where you look. So just very simply, if you give a transdermal hormone, typically you're going to get a small increase in serum or urine, and you're going to get a huge increase in saliva, which of course creates two different clinical messages from the results, and we've got to sort through that and figure out, what exactly does that mean. So we showed this data before, but this is from the data from the study that was recently published that I was involved in, where again, the serum results, this is venous serum, it's not going anywhere during this study, yet saliva and blood spot tells a fairly similar story in that there's a significant increase over time. And the saliva gland is a result of tissue hormone. The blood spot is capillary blood. It's more analogous to what's going to be in a tissue than is venous serum. So these would imply that tissue are really getting a lot of hormone, whereas the serum's not seeing it. So with transdermal cream, the testing minion that you've got to look out for is a very significant one, and I'm gonna really highlight cream versus gel as we go forward, because there is a distinction, and we'll get into that at the end. But serum and urine testing, you're really looking at, it appears, a significant tissue underestimation when you're using transdermal creams in serum and urine testing, because saliva teaches us that some tissue get more hormone, and blood spot confirms this, than is reflected in serum or urine testing when you're using topical hormones. So we've seen this data. That tells us kind of this message that we're centering on. And if we look at this data, now we're not looking at a change over time. And the other one we were looking at, 4 hours, 8 hours, 12 hours later. Now we're looking at, well, what do these values do when we increase the dose? And you can see with serum values, this is topical progesterone cream. And you can see that the serum values, they're not going anywhere at 80, 100 milligrams. Now, you can tell anecdotally, I haven't really found it in the literature much, but if you talk to people, when you start using 200, 400, 600 milligrams of progesterone, you will get a slight increase. But at these doses, there really is not much of an increase at all. Whereas with saliva, you've got a nice linear dose-dependent increase. So that tells you something pretty significant about what's going on, at the tissue level. But do note that even with a 20 milligram dose, this is well above a physiological value. And these are numbers at 24 hours. These are 24 hours after your last dose. So at 8 hours, 12 hours, you're way above a physiological level of progesterone. So let's just look at these, though, and ask the question, do these methods, blood spot and saliva, work for monitoring hormones? So with blood spot, we've got what I would say are significant issues, or minions as we're calling them, in terms of being able to actually use it to monitor hormones. And those are sample-to-sample variation, which is very significant here, and contamination. So let's look at this study. So what we've got, when you really parse through the data, you have 14 people who have taken transdermal progesterone and then monitored 3 times within sort of the testing window. The idea is take your hormone 12 to 24 hours after you take it, test. Okay, so over the course of this study, these people have done that 3 times. So that's what your values are here on the y-axis, are the different values. Now you only see 12, and that's because of the 14, 2 of them were considered to have contaminated samples, and so those were eliminated. Now we should say, in terms of the issue of contamination, these people wore gloves when they put the hormone on every day, and then during the study they put the hormone on wearing gloves. The hormones went on their inner thigh, so that's an area that's covered by clothes. So this is actually a best case scenario, really, in terms of avoiding contamination for blood spots, because normally people are putting it on with their hands. They're putting it on their forearms, which is very close to the fingertips. So in terms of contamination, this is a best case scenario, and 15% of the data was eliminated because of that. So that's something that we've got to be aware of. But the biggest issue here is the sample-to-sample variability. So if you look at individual number 1, you get a low result, a normal result, and a high result. Now this is using a pretty broad range. We're looking at 8 to 33 nanograms per milliliter, which is a range taken from a particular group. And you can see, again, this person is low, normal, and high, given the 3 samples within the testing window. So if our testing minion of variability from sample to sample increases one value to an elevated level and takes another one down to a deficient level, then you've really got an issue here, right? If you have a patient that tests and you get a normal value, and then the patient says, oh, by the way, doctor, just so you know, I've got some extra money, so I went ahead and tested 2 extra times within the window that you asked me to test, just so I could really confirm my value. And you say, okay, well, what's the value? You say, well, one of my values was a 20, and one was a 3, and one was, an 85. So what are you going to do with that information? If it's not reproducible enough that you can actually get a consistent value, or at least a consistent message from those values, then it's going to be impossible to use this to monitor level. So we've got a false low due to imprecision, not laboratory imprecision of the lab not getting the right value, but just the fact that the blood coming out of the finger stick, for whatever reason, is bouncing all over the place as we test from one time to another. Okay, so if you work through the rest of these people and you look at the message, person number 2 is low twice and is normal once. For person number 3, this is actually the only person in the whole study that got a consistent message. High, higher, and highest. So that person actually got a consistent message. Now, when you go look at the saliva values from that person, one of them was high and 2 of them were actually low. So it's very difficult in this to get a consistent message. As you keep looking, here's person number 4 is low normal and very high. Person number 5 is low normal, high. Person number 6 is low normal, extremely high, 7. And you keep working through that. And what you find is there are actually 6 people out of 12 that have both a low and a high result. And nobody in the study has 3 normal results or 3 low results. One, as we can see here, as we already pointed out, has 3 high results, but it's much more likely to get drastically inconsistent results than it is to get a result that's actually consistent from one measurement to the next. So this is really an insurmountable issue in terms of using this type of a test to monitor your dose and think, oh, well, I'm going to increase the dose or decrease the dose or whatever it might be, if you can't get the same number if you collect the sample repeatedly. So with transdermal hormones and saliva, we've still got the contamination issue, but it's a little bit easier to control than the blood spot. Like I said, with the blood spot, when you're putting hormones on with your hands, and there are literally millions of nanograms of hormone in that hormone, and then you're trying to tell the difference between 0 and 1 and 5 and 10 of the same units, it gets pretty difficult. So for saliva, if we're able to eliminate the contamination entirely, really the 2 big issues here are, again, sample-to-sample variation, and as well, the location dependence. Now, the sample-to-sample variation, I'm not going to go through the data here. If you want to see some data on that, I can show you. But what we're really going to talk about is the issue of location dependence, because this isn't just an issue in terms of of introducing variability into the testing, but it's really more of a fundamental issue in terms of what is actually going on that causes the saliva values to increase and whether those actually reflect systemic tissue levels or not. So we've shown that if you increase the dose of topical progesterone, the saliva values go up in a linear manner. If you measure enough people, right? There's a lot of variability within each one of these data points, but when you look at the averages, it does have the trend you'd expect to see, linear dose-dependent results. So if this is kind of the model that we're looking at, the problem is if, without adding any more hormone, you can increase the values significantly, that's a problem. And that indeed is the case here as you look at this data where we look at the question of what happens when you move the hormone. So what we're looking at here are basically how far away from the saliva gland did you put the hormone and what's the peak value. Now these are not the values you would find, just to full disclosure, these are not the values you'd find when you test. These are peak values. So that would be normally maybe 3 hours, 4 hours, 6 hours, something like that. And then you're typically going to test at 12 hours or 24. But if you've got a big peak, obviously as it comes down off that peak, the values at 12 and 24 hours are going to be likewise different. But you can see here the peak value around the saliva gland is close to 100,000. And then it comes down, and there is a relationship. That's the point. There's a relationship between how far away from the saliva gland you put the hormone and what the value is. And it is not a gentle curve. If you look at this, a logarithmic scale. So we're talking about a change of more than 100-fold by just moving the hormone around, which we'll get into a little bit later what that might mean in terms of how the hormone is actually getting in. But this is not something that's standardized in terms of people always putting the hormone in the same place, and this is a very significant variable. Now in the study we just showed, they put it all in the same place, and in spite of that, the values really bounce around from collection to collection. It's very common to see, someone have a 200 at one point and then a 2,000 at another point, both within the windows within which your patients would collect. So even if you standardize this, the values really have a lot of wiggle, if you will, from collection to collection. But then as you go from one person to another in terms of where they're putting it, that can be even more dramatic in terms of how it can change the values. So when you're looking at transdermal hormones in saliva and in blood spot, there really is a profound message to be learned, and that is these are sort of tissue type levels of hormones, and they legitimately increase very, very significantly, which tells you that the levels you're seeing in urine and in blood are not numbers that you want to base your dosing off. But when you look at actually using those numbers and trying to ask the question, how is my dose? Do I need to go up? Do I need to go down? It really is very problematic in terms of trying to eliminate these variables, because you can't. Sample-to-sample variation, the location dependence, and the contamination are just really too much to overcome. So it also begs the question, if saliva was a meaningful value here and blood spot was a meaningful value, they certainly should be telling approximately the same story, right? So in this study, we've got a whole lot of data. Here you can see how many points there are, where we've got simultaneously collected saliva and blood spot. And you can see the increase, yes, they go up. And we saw that they go up, but even within a person, they're bouncing all over the place. So when you try to correlate saliva to blood spot to say, look, are they telling the same story? They're really not at a given time. You can see the correlation here is quite poor. If we look at overall hormone exposure, so on the left graph what we did is said, okay, let's look at the cumulative effect, so the average value for person number 1 over a 24-hour period, the average value for person number 2, and when you do that for blood spot, from which we had maybe 6 measurements, and then the saliva, which we had a few more measurements because it's a little easier to take, there's absolutely no correlation between what the story that the blood spot tells. Are you high? Are you normal? Are you low? And the story that the saliva tells, they don't agree with one another. When you really dig through the data, and I've done this, trying to be as generous to the data as you can be, this is the best I could come up with, was if you look only at 12 hours, if you look at 24 hours, there's no correlation. If you look at 8 hours, there's no correlation. At 12 hours, I wouldn't call this modest correlation. That's the best that the correlation got, which it's still not great, but that's as good as it got. So do blood spot and saliva agree? They really don't. The only agreement is that over time, hormone floods a blood spot and floods saliva, but not in any way that you can actually measure it in a meaningful way. So if we step back from that a little bit, let's ask the question of whether these values, these very elevated values, actually represent systemic hormone exposure, because that's really a big question, right? If I put progesterone on my forearm and I'm a female, is it getting to my uterus? If I put testosterone on my forearm, is it going to get to my brain? So testosterone's got probably the most data on this, so let's take a look at that. So if we take too much testosterone as a man, then the luteinizing hormone is going to go down. When the brain gets the message that we have too much hormone, then that's why the testicles shrink in men who take too much testosterone, because LH is not going to expose itself to the testes. So if you take, for example, a large weekly injection of testosterone, it can suppress LH entirely. So with a 50 milligram transdermal gel, now this is not a cream, it's a gel, so it's a little different here, but the saliva will go up 15-fold. So what's the message there? Massive dose of hormone. The serum and the urine will go up modestly. So what about LH? Does it agree with a modest change or this massive increase in hormone? Which, if we had a massive increase in hormone, you'd expect these LH values to go all the way to 0. Now, these are not in normal men. These are in hypogonadal men. So this LH value at baseline is elevated. 50 milligrams brought men down right here, right in the middle of the reference range. So if you're in the middle of the reference range, basically the message to the brain here is, I'm low on testosterone, I need to make more LH. And then as we give 50 milligrams of a gel, the message is, hey, you got it just right. It's a modest dose of testosterone, not a massive dose, or that's the message the brain gets, which differs from what you see in saliva and in blood spots. So it agrees more with serum or urine testing. Now that doesn't mean that's what's going on in any other tissue, but that is interesting. And if you look at muscle mass increase with transdermal testosterone gels, when you split people into the group of people whose serum went up significantly and people whose did not, the muscle mass increase is only seen in the group where the serum goes up, whereas the saliva is going to go up in either group. So there you've got some issues in terms of whether those salivary and blood spot values reflect systemic exposure. So these are the results. With serum, you're going to get small to no increase, which I would consider a clinical underestimation. In urine, same story. Now, the metabolites in urine can sometimes help. I'll show you an example of that at the end in terms of giving you some more information. But in terms of the actual value of the hormone you're taking, I would consider it a clinical underestimation, and sometimes very significantly, especially with progesterone. With saliva and also with blood spot, you're going to get high physiological in blood spot to super physiological, but in saliva, definitely super physiological levels. But the variability is really, really high, and I don't think the data supports them representing systemic levels. So then that, of course, begs the question, what in the world should we do as providers? So let me introduce one other concept into this, which I think long-term may change the nature of this debate and this conversation quite a lot. When we look at topical progesterone, let's look at the progesterone data again. You take saliva, and this is true of blood spot as well, as you increase the dose, generally speaking, again, there's a lot of variability in here, but generally speaking, the dose in saliva goes up. In serum, here's your sort of normal range up in here. You really aren't getting off the ground at all here, even with 80 and 100 milligrams. Now, let's look at testosterone. With testosterone, again, in saliva, it's interesting, in saliva, the values are almost identical to progesterone. So you take this transdermal hormone, and bam, the levels go up about the same amount. When you take testosterone, you look at the blood levels, you look at these, you're getting up at 100 milligrams, you're up and over 700. So that's very well into the normal range. So if you look at progesterone, you're not anywhere close. So with testosterone, you are. Now, why is that? I would submit it has nothing to do with the difference, or very little to do with the difference between the two hormones. Almost all the progesterone, and certainly this data, is based off of progesterone creams. But if you look at this testosterone data, it's based off of androgel. This is an alcoholic gel, and there is a very big difference between using an alcoholic gel and using a cream. Now, if we look at this testosterone data, there is actually data that shows that serum progesterone gets up around 8 when you take topical progesterone as an alcoholic gel. The interesting thing about this study that was just completed is, and this is where the topic can get so confusing, is it says right in the title, this is gels and this is creams, and as you look at the data, none of them go up. And that's because there was an error in this study. Yes, it's a cream, and yes, it's a gel, but it's not an alcoholic gel. The request was made for an alcoholic gel because Dr. Stanzik has been sort of on this topic, and he's seen it. He's the one that showed, wow, we can push levels to up to 8 in serum with an alcoholic gel. So this study completed, none of the serum values went up, and then we went to the, they went to the compounder and said, was there something different with the progesterone? And they, told them how they did it, and oh, lo and behold, it's water-based, it's not an alcoholic gel, so it essentially just becomes another version of a cream, which showed the same data. There's no increase in serum, but there is a huge difference between alcoholic gels and the creams. So what does this mean? If you really look at the issue of the values going higher as you put the hormone closer to saliva, it really should reshape our understanding of how this is happening. Now, if you add in this data, this again adds to this conversation. If you get off of a progesterone cream, look at these values. They're sky high for 6, 7, 8 weeks. It starts to come down. It's more than 12 weeks before those values come all the way down, which is certainly makes us think about fat solubility and a fat reservoir of the hormone. So if you put the hormone very, very close and the saliva values go way, way up, and you put it further away and they go way, way down, that would tell me that it's not likely that these hormones are dumping into the main circulation and then being, circulating through the body and then being distributed to the saliva gland. It's much more likely that there's some sort of diffusion, whether it's through subcutaneous fat, some of the subdermal lymphatic. I think it makes a lot of sense that those two things are involved, which again starts to reshape our thinking. But it could be that with an alcoholic gel, you get deeper penetration either into the deep lymphatic, which dumps into the serum system, or potentially into the blood capillaries or some other system that's going to dump it into the systemic circulation at a certain level. Now, you're still going to certainly get a huge reservoir of hormone in the fat, which is going to increase the saliva levels. Saliva looks the same. Creams, gels, doesn't matter. It looks pretty much the same. But when you use the alcoholic gels, up go the serum values. Okay, so I think as this is explored, I really think we're going to come to find out a little bit more about this, and this will become hopefully clearer as time goes on. I think if you're thinking about the lymphatic system, here are a couple pictures to make us think. One, here's a saliva gland, and the little raisin-looking bumps here are lymph nodes, right? So there's a lot of lymph in the salivary system, and so that's interesting. If you look at a hand where the blood spot's coming from, look at the lymph capillaries all over the place in there. So there may be that the transport mechanism involves lymphatics. There's a nice paper where they looked at testosterone, some testosterone conjugate that was being taken orally, and it increases your systemic levels. And come to find out, the transport was entirely lymphatic. The lymph in the gut was picking it up. Now this is the deep lymph system, not the capillary or the subdermal lymphatics, but and it would pick up the hormone and dump it into the vena cava, and then it would go around, and that's how it got into blood entirely. So it's possible that that's the case, which opens up a whole new set of questions about what's going on. So my best guess as to what's going on, which is again a lot of conjecture, is in this study that we looked at, they put hormone on the inner thigh. So an interesting observation from another study is when they looked at progesterone levels in the back fat of pigs, they found that when the pigs ovulate, they make progesterone. And about a day later, the progesterone would diffuse through the fat. And they noted that the half-life of progesterone in back fat was 34 hours. So if every 24 hours you're slapping on more hormone, and the half-life is 34 hours, you're going to fill up all of this fat, which the lymph is going to feed into, with a ton of hormone. And then somehow it seems to me that that hormone is finding its way into the fingertips and into the saliva gland. Both are areas that are rich with lymph vessels of some type. But as you get into like, okay, what does this mean for testing? If you look at the way the lymph works, this picture shows that the entire left side empties the whole bottom trunk of the body and the left side, and the right side only empties this part here. So if you're looking at, for example, blood spots, there could actually be a huge difference between left and right hand in terms of how the connection is with the lymph. It just introduces a lot of complexity in terms of what this means. But if we go back to the basics and look at the testing minions, and we see that, wow, for whatever reason, when you test these things, the values bounce around a lot based on variables that you cannot control and that you cannot standardize, the most basic of which is from one collection to another. Within the testing period, the values are just highly variable. So what should we do? I think the use of alcoholic gels might make a lot more sense because you're going to get serum and urine values that increase to reasonable and intuitive levels. I've seen it with estrogel. I've seen it with testosterone gels. You get much more of an increase in urine or serum, which is probably reflective more of your systemic levels. But it probably makes sense to use conservative values because it's likely still a tissue underestimation. Because what do we know? At those same times, the saliva gland is full of hormone. The blood spot, for most of the times that you sample it, is full of hormone. So likely there are other tissues that are getting more hormone than is reflected in serum or urine. So you probably want to use conservative values, as well as being careful of where you're putting the hormone. For example, not putting estrogen by estrogen-sensitive tissue. Maybe think about a different route of administration. We might want to come to the conclusion that if you're going to use a cream, put it on a mucosal membrane, vaginal, anal mucosa. Sublingual hormone is, obviously you wouldn't use a cream, but that's the same type of delivery in terms of a mucosal membrane uptaking the hormone. When that happens, serum goes up, urine goes up, saliva goes up. It's a much more intuitive situation in terms of how we can understand and how we can track these situations, and then know the limitations of all of your tests. So understanding what we've just gone through and understanding some of the variabilities that's going on, of course, if you're using a transdermal cream, understanding that what you're seeing in serum and urine is likely, for a cream, probably a gross underestimation of what's going on in some tissues. So it doesn't mean the transdermal creams are not effective clinically. They may well be in many situations, but if you want to monitor them, then it gets a little bit different. And with topical creams, the biggest message is you really can't, with a cream, you really can't chase any of the lab values. I'm going to go for this target value in blood spot, I'm going to go for this target value in saliva, or I'm going to go for a young, healthy level in serum or urine. That can lead to a lot of overdosing, and with the saliva and the blood spot, it can lead to a lot of chasing your tail, because again, if the same patient collected, again, you'd very, very likely get an extremely different value even if nothing has changed. So here's an example of a transdermal cream where we're trying to make some sense of it, and you can. Here's a urine value. Someone taking testosterone. This is a man. Now you can see he's up at the higher end of the normal range. His testosterone is actually increased from the cream, but what do you know is that's probably an underestimation of his overall testosterone burden, and particularly with some tissue. Now when you look down here at testosterone, it gets turned into DHT and then into this metabolite. If testosterone gets taken up into a cell, it can get turned into DHT. If it does, it gets turned into this metabolite, and that gets excreted. So you can look at this and see that obviously the tissue are uptaking a lot of testosterone in this case. So as you look at the overall picture, you can get some meaningful values from this, and you can see also for this patient, he's making a whole lot of estrogen out of his testosterone. So there's some meaning to these values, but again, just looking at the absolute value of the hormone you're taking, that's where we find you have to use some caution. So if you have some questions on this topic, or you'd like to contribute to the conversation, I'd love to get any data that you have, whether it's from a study or just anecdotal data from your clinical practice of, hey, I use this dose transdermally, here are the serum values that I see, because this conversation really needs to be a fluid and dynamic one, because there is obviously a lot left cumulatively to learn, so that we can give patients the best care possible. And thank you for your time.